here because my social I just present as virtual. Today we will talk as basal cell carcinoma arising from the epidermal cyst. Why this? Next slide, please. Next slide. Why this case is very important. Epidermal cysts we know are common, but malignant transformation is rare. When it is happen, squamous cell carcinoma is the most common cause. Because as we know, any long-standing skin lesion, always the common complication is squamous cell carcinoma rather than basal cell carcinoma. The basal cell carcinoma, when arising from epidermal cyst, is exponential. From the reviewing the 3,300 cases, more than 90 cases is squamous cell carcinoma, and only we have 12 published English language basal cell carcinoma cases. Our cases is the 13. Next, please. Next, please. We present this 60-year-old female, Saudi female, known case of hypertension, present with slowly enlarging nasal dorsum lesion for 4 years, associated with mild itching, no ulceration, trauma, or barrier surgery. On examination, we have well-defined 3 by 3 centimeter firm nodule with telangiectasia and 2 punctum. We have white keratinous material expressed on and off. We don't have lymphadenopathy in this case. Next, please. The examination, we have lesion that behaved as like cyst but looked clinically atypical, firm, well-defined dome-shaped nodule, surface telangiectasia and erythema, 2 punctum with the keratinous material, no ulceration or regional lymphadenopathy, progressive growth over 4 years. We have for me, when I saw this case, the lady said for me this 4 year and enlarge, and I think this one is more important than cyst. And even this one, the lady said we have cheesy material coming outside. I told her no, we have to make excisional biopsy, and then we make this excisional biopsy. Often we in dermoscope we see telangiectasia, and when we make this skin biopsy, we found basaloid proliferation with cystic space, and when we did immunohistochemistry, we find BCL2 and CD10 positive. That's marker for basal this one basal cell carcinoma. For that reason, excisional biopsy is work as both diagnostic and curative diagnosis. This is the histopathology by high power. The second please slide. The histopathology, we found well circumscribed basaloid keratinocyte proliferation with cystic space, and we find also tumor with cystic structure, basal cell enlarged. Next, please. Next, please. The marker for positive staining, supportive basaloid carcinoma phenotype, and help in diagnosis. These 2 marker, BCL2 positive and CD10 positive. Next, please. Maybe this proposed the pathogenesis may be due to long-standing. This one of the cause epithelial resistance. And also with chronic irritation and minor trauma can cause mechanical stress to the skin lesion and epithelioid instability, tumorigenic portal, and also sun exposed. As we know, basal cell carcinoma common in sun exposed area. Next, please. A review in the most common literature reviewed in this basal cell carcinoma, we found 12 and our 13 is 8 of out of 13 is extrafacial location, and the mainly year the different year from 4 year and to long time due to maybe delay in diagnosis, and the excision is standard diagnosis treatment and workup. Next, please. This the 13. As we see, this one is most is fair skin type from the Europe and US, and the age is almost most of the cases above 50, and the duration is different from center to the center. The site is extrafacial most likely. Next, please. Next, please. The 4 year duration is and this our the management for after excisional biopsy and the clear margin, and we have this one follow up. The patient is now is okay. The take home message is don't dismiss growth. Any skin lesion, progressive, enlarged, cyst deserve excision and histological review, even with uh, normal presentation. And the basal cell is rare in cyst. Most common is squamous cell carcinoma, and the histology is decisive. Is very mandatory to do histology in every cyst to make good follow up for the patient, and the excision is curative. Clear margin is are the key management. This is my reference, and thank you for the.
Everyone, I am Dr. Nubaira Tasneem. I am from Bangladesh, and today I will talk about the topical steroid damaged face, and this will be a chronic public concern in the South Asia. This is a clinical problem, and the approaches and paper active work from Bangladesh. Please go to the next slide. Please move into the next slide. Okay, so I have already given you my introduction, so I will start from the problem actually. So topical steroids are widely used in our whole world for so many dermatitis and the problem, but the misuse is very, very increasing in South Asia. And this is actually causes one problem which is called TSDF. And this is a preventable condition, but this is very rising right now in our country because for these things people want to get a very fair skin, which is not possible for everyone in every time. So in case of public health importance, public prevalence in Bangladesh and neighboring countries where the uh, where this type of ointment, which is actually a steroid, but people are using it for whitening their face, are found very available in over the counter drugs, and which is actually driven by the customers for the fairness culture and also by the influence of the social media. So, what is actually this TSDF? TSDF is actually a chronic dermatosis due to the steroid misuse on any type of the body parts, mostly on the face. And this is often mixed with antifungal or antibiotic creams or any other beauty creams. And this is actually not at all a pathological condition, but this is completely a man made condition. So, what are the common steroids we misused in our countries? And that is mostly clobetasol, betamethasone, and then mometasone and other combinations in form of the creams. So this is a photo showing the telangiectasia in a face who used these ointments as a beauty cream. So pharmacy without prescription in South Asia are giving these things. People are influenced themselves by social media and sometimes the friends and family advisors and sometimes from the local beauty parlors or from the beauticians. So mostly females who are in the teenage or in the early adults are using these creams as a fairness one. And right now we can also see so many patients who are males and also teenagers. So what actually that steroid cream causes? When people are using repeatedly every day, twice or once a day, then there is vasodilation, there is epidermal thinning, immunosuppression, and barrier damages. So this is a phase of our patients who shows erythema and patients are experiencing burning and also shows telangiectasia and sometimes acneiform eruptions. So there are some advanced manifestations other than the clinical features where can be steroid rosacea, perioral dermatitis, hypertrichosis, pigmentary changes. So this is a clinical features which shows telangiectasia and the severe TSDF phase. So there is a diagnostic challenges which we face every time because people are not always willing to give us the history because they know that using steroid cream is not good for their skin, but they are addicted to get fair and sometimes they are hiding their history of using this type of steroids cream, which is a very challenging for the doctors in this community. And sometimes these things can mimics the rosacea, acne, or dermatitis. Our diagnostic clue, the first thing is history of fairness cream or instant glow. We have to ask them repeatedly. Here I am showing some forms of the creams which are very popular in the South Asian local markets. So management challenge. At first, whenever we just tell our patients to stop that cream, there is a withdrawal effect. So we have to tell our patient repeatedly that there will be some withdrawal symptoms and he or she needs to cooperate with us. There is a skin dependency on the steroid and this recovery phase is very slow and compliance issues is always there because people are facing very much black or very other symptoms after the withdrawal and they don't want to comply us with that time. There is also very psychological impact which we have always seen in our patients like anxiety, low self-esteem, social withdrawal effects and always in a very much underconfident state. So treatment principle, first we need to stop the steroid counseling and counseling. This is the only one option to for treatment starting position. And then we have to go further damage repair of the skin barrier and then we need to give the anti-inflammatory therapy. So if need to talk about the treatment protocol, then sometimes we need to use tacrolimus or primaclorimus. the calcineurin inhibitors. Emollients is must. If there is any acne breakout, then we need to go for the doxycycline, and sunscreen is must. The sunscreen role is very, very important in case of TSDF withdrawal phase, because whenever people are in any kind of heat or any kind of sun exposure, then there is worsening of the erythema. So sunscreen can prevent that. It can protect the barrier and reduce pigmentation. What we cannot do, that is also very important. We have to avoid any kind of skin actives just after withdrawal of the steroid creams. No peeling, lasers, or anything harsh in acute stays. This is prognosis is very slow, to be honest. Sometimes months needed. Some persistent sensitivity will be always there in some patients. In South Asia, the steroid can be easily found in the over-the-counter drug. Anyone can buy this. Cultural beauty pressure is always there, that fairness is the only key for the beauty, and low awareness is another cause for this crisis. Social media has another role because they are always showing some kind of DIY skincare trends. Influencers are giving the misinformations, and there are so many hidden steroids in so many creams which people are not aware about. So what we can do, we need to give them the regulatory issues, like the enforcement can be strong, our product can be labeled well, that which is containing steroid, which doesn't, and the availability should be turned into a strict condition that steroid should not be sold in over-the-counter facilities. So this is actually flag of our countries, and I have seen a real patients of mine who was be on steroid cream, and the before after is showing here. So for prevention of the strategies, we can do the regulation of the steroid cream use and also the selling, and we can create awareness. And dermatologist education is very important so that we can educate our patient who are coming with the minor side effects of the steroids. So our role as a dermatologist in this case is that we need to go for early diagnosis, we need to educate our patients, and we can make some videos and we can give some social media advices which is regarding the steroid misuse to our patients. There are so many myths in our countries and the neighboring countries that instant glow is face, but it causes actually the damage. Occasional use is safe, it's not true. Even short misuse can be very, very harmful for skin. There are always some DIY and hidden steroid in so many whitening creams, in bridal kits and online products, so we need to be very careful before purchasing that. So in case of future directions, what we can do is we can make our policy very straight, we can make our public educated, and we can do some research-based work to show our people that what is the before and what is the after problems of using steroid cream. So my take-home message for today is TSDF is preventable. This is a major health issues in our countries right now, which is completely man-made, and education is the only key to prevent it. So my acknowledgements to all of you, my institutions and my patients and the organizer of the conferences, and I like to thank all of you to give me 3 times chances today because my microphone was not working, and I really, really appreciate that.
Hello everyone, myself Dr. Piyush Yadav, and I'm a consultant dermatologist at RUHS India, and I'll be the next speaker for today. First of all, thanks to the organizing committee of Fourth International Conference of Dermatology and Cosmetology for giving me this wonderful opportunity. And my topic of discussion today will be autonomic denervation dermatitis. First of all, there are no conflicts of interest. And this is my presentation overview, including all the points that we are going to discuss in this presentation. So, autonomic denervation dermatitis, it is a localized eczematous eruption occurring at a site of previous surgical incision and the adjoining skin, usually after a lag period. And the eczematous eruption is caused by the traumatic transaction of dermal autonomic nerve fibers. The ADD is an umbrella term and include all the eczematous eruption which occur at any surgical site following any surgical procedure. The skin tech, which is a subset of autonomic denervation dermatitis, is usually only limited to the total knee replacement surgery. And another term, neuropathic dermatitis, is now considered misleading and usually not used anymore. And the post-traumatic eczema, it is a different entity with because which happens because of the non-surgical trauma and has a different pathomechanism, and we'll discuss about this in a bit. So here we can see a patient who underwent total knee replacement a while back, and on the surgical site of incision, the patient has developed dry xerotic eczematous plaque, which we term now as skin TED. It is an acronym which stands for surgery of the knee, injury to the infrapatellar branch of the saphenous nerve, and traumatic eczematous dermatitis. You can see in the picture that the infrapatellar branch, infrapatellar nerve of the saphenous nerve, is transected in the TKR, which leads to eczematous eruption over the surgical site. So coming on to the pathomechanism, why do ADD happen? First of all, you have to remember that the autonomic fibers innervate all these structures in the dermis, including blood vessel, lymphatic, glands, muscle, and the hair follicle. And because of this, all the disruption that happens because of nerve transaction affect the autonomic functioning of the normal skin. There is the catecholamines and the acetylcholines, which are released from the autonomic nerve endings, which regulate the keratinocyte proliferation, addition, migration, as well as differentiation, are affected in such transaction. And there is also impaired pseudomotor function, which is a key contributor to the eczema. So in stepwise manner, first of all, a surgical incision takes place. There is traumatic transaction of the dermal autonomic nerve fibers, followed by autonomic denervation, which leads to loss of pseudomotor function as well as the mesomotor control of the skin. There is increased transepidermal water loss and a skin barrier breakdown happens, which leads to dry xerotic plaque. There is also neuropeptide imbalance of substance P, acetylcholine, catecholamine, which are released from the nerve endings, which finally leads to an eczematous eruption localized to the surgical site, which we call as ADD. And ADD represents an immunocompromised district zone, a zone where surgery creates loco-regional immune dysregulation through the nerve transaction, the lymphatic disruption, and the barrier failure, which predisposes the healed site to develop eczema, which we call ADD. The ADD patients usually present with dry, scaly, xerotic papuloplaques, which can have oozing, crusting, and fissuring. The site is usually around a healed surgical scar with predominance over of the lower limbs, usually not limited to just the knee scars. There is usually a lag period of 3 weeks to 3 year post surgery, and there is a mean lag period of 6 months for patients undergoing total knee replacement. There is also altered sensation, hyposthesia, and sweating can be reduced because of the autonomic dysfunction. And on histopathology, the picture is very non-specific. We get a chronic spongiotic dermatitis pattern with dense lymphocytic infiltrate, and there are no acute inflammatory infiltrate cells. The ADD usually pursues a persistent relapsing remitting course. The patient will complain of the lesions, vaccine-winning lesions, which develop and which worsen during the time of winter as there is cold, dry weather, which further leads to barrier compromise and flare-up of eczema. The lesions usually may self-resolve over months or may respond promptly to the topical steroid which patient may take from over the counter. The ADD is usually unilateral. The bilateral ADD is uncommon even after the bilateral TKR. This phenomena has been attributed to the anatomical variation in nerve course between the two limbs. There is predominance of lower limb, as we can see in patients who underwent coronary arteries bypass grafting. The site where from the venous graft has been taken usually develop ADD, but the chest scar is usually spared in patients of undergoing CABG. There is lag period is very wide, very variable, the onset ranging from 3 weeks to 3 years. So we had a case report of 5 such patients which we recently published in Curious, which we had in which we had 5 patients, three of which who underwent any surgical procedure, including open reduction internal dissection for the left tibial fracture and total hip replacement. The lag period ranged from 2.5 months to around 3 years, and the patient were labeled as ADD, whereas 2 patients had mechanical trauma on the shin when patient developed an eczematous plaque around the scar site 4 to 5 weeks after the trauma. We also did gram stain and KVH for the patient, which were negative, and the patient did had any venous stasis, nor any topical allergy history, and the patient denied biopsy because of the limited nature of the disease. The treatment was given including topical emollients as well as mild topical corticosteroids, and 3 out of 5 patients followed up with near complete resolution within the 4 weeks. So these 3 images showed the patient of autonomic denervation dermatitis. The patient underwent a surgical procedure following which there are very dry eczematous uh, plaque around the surgical site, both on the lower limb as well as the hip area. These 2 pictures shows the patient of post-traumatic eczema. The patient had a history of mechanical trauma, and the eczematous eruption occurred around the surgical site. The clinical picture of both post-traumatic as well as eczema as well as ADD is usually similar. So how we differentiate both of these? First, ADD is limited to the healed surgical scar and the adjoining skin. There has to be a history of surgical incision, be it any site or any procedure, and the onset is usually months to years after the surgical intervention. Whereas in cases of post-traumatic eczema, the type of injury is usually mechanical, thermal, or chemical injury, mechanical trauma, and there is no history of any surgical intervention. And the lag period is usually shorter as compared to the ADD, with ranging from 2 to 4 weeks post-trauma. The pathophysiology is a bit different. In case of ADD, there's autonomic nerve transaction leading to barrier disruption, whereas it is more of inflammatory response to trauma in cases of post-traumatic eczema. And there can be a history of atopy present in patients of post-traumatic eczema. And in cases of ADD, the patient have a lower limb production because of the poor blood supply and the denervation synergism, whereas post-traumatic eczema does not have any winter exacerbation nor any specific site predilection. So ADD is a diagnosis of exclusion. So we have to first rule out different entities, including steatotic eczema, allergic contact dermatitis, metal implant hypersensitivity, and venous stasis eczema. In cases of steatotic eczema, the patient will be elderly, presenting with dry skin, winter. The lesion will be very diffuse, not localized to the scar. And especially there is no hypostasia and there is no history of any surgical intervention. In cases of ACD, the patient can develop ACD to iodine, dressing, adhesive, following a trauma. And it is usually localized to the area of application. We can also get a positive patch test to the causative allergen, which the lesion will resolve on removal of the allergen. Metal implant hypersensitivity, it is generalized around an implant and not usually scar specific. The patient can have swelling, effusion, and a positive patch test to the metals. And the disease usually persists until the implant is removed and usually requires orthopedic collaboration. In cases of stasis eczema, there is associated varicosity, venous insufficiency. There will be signs of stasis like hemosiderin and lipodermatosclerosis. In an investigation, there will be abnormal venous Doppler, and both the legs are usually involved in cases of stasis eczema. So, a stepwise diagnostic approach will include history of any surgical trauma, the site and nature of the surgery, the exact timing of skin lesion onset related to surgery, and absence of any topical allergen use and any family history. And clinical examination will show us an eczematous xerotic plaque, which will be centered at and around the scar. There will be hyposthesia, and there is absence of varicose vein, venous stasis, and there is absence of perilesional edema. Investigation is generally done to rule out any mimics like gram stain cavity scraping is done to rule out any infection. Patch test is done to rule out any contact allergy, and venous Doppler to rule out stasis eczema. Skin biopsy is usually limited to only selective cases because the skin biopsy is very non-specific, and we'll get a chronic spongitic dermatitis pattern, the dense inflammatory infiltrate, and there will be no acute inflammatory cells. A referral to a orthopedician can be can be done to communicate the treating surgeon regarding any implant or metal hypersensitivity. And in also cases where the orthopedician usually refer the patient to us because of the eczematous eruption over the heel scar. So in that case, we have to reassure both the patient as well as the surgeon there is no surgical intervention required and it is ADD. Management of ADD includes skin barrier repair, which is the cornerstone of the long-term maintenance. Liberal emollients and occlusive moisturizers are given, especially in the winters, and the patient should be advised against using any harsh soap detergents and irritants. Anti-inflammatory therapy is usually given to control the short-term exacerbation of the disease, and it is a good thing that ADD is a steroid-responsive dermatosis. There we can give mild to moderate potent topical corticosteroid, and we should discourage long-term use of superpotent steroid. Though in severe cases, we can give a short tapering oral prednisolone or steroid, and oral antihistamine for symptomatic pruritus has to be given. The patient counseling is the main point. The patient should be counseled regarding the chronic, relapsing, remitting nature of the disease, and we should tell the patient about the winter exacerbation. The reassurance should be given to the patient that is, and as well as the treating surgeon that no effect on joint function or implant integrity uh, is there in cases of ADD. And the prognosis of the lesions is usually the lesions self-resolve and respond well to topical corticosteroids. So why every dermatologist should know ADD? First of all, it is massively under-recognized given the total prevalence of total knee replacement. And the disease is usually frequently misdiagnosed as it is labeled as contact allergy, implant reaction, stasis eczema, which leads to unnecessary investigation, referral, and patient anxiety. There's also cross-specialty condition. The doctors have to keep in mind that the patient present to dermatologists without any clear surgical context, and and the patient as well as the orthopedician should be made aware of such entities. The treatment is very simple and straightforward, using emollients and topical corticosteroids, and early recognition avoids patient distress and unnecessary surgical interventions. So my take-home message will be the introduction to ADD, as it is a very newer entity, the localized eczematous eruption at a heel surgical site, which developed months too later because of the autonomic nerve transaction. Kinted, which is a site-specific subset of ADD, usually occur at the site of total knee replacement scar because of the transaction of interpatellar branch of the saphenous nerve. And the key differentiation from post-traumatic eczema include timing, the wound state, presence or absence of atopy in the patient, and pathophysiological difference. And one should remember that ADD is a diagnosis of exclusion, and we should rule out the contact allergy, metal hypersensitivity, stasis, infection before labeling the patient as ADD. The treatment is usually straightforward with liberal emollients and topical corticosteroids, and the patient should be counseled regarding the chronic relapsing remitting course, especially the winter worsening. And a greater awareness among dermatologists and orthopedicians is required with cross-specialty management for such cases. These are my references, and thank you so much for listening to my presentation. Thank you.
afternoon, dear colleagues. I'm very happy to see all of you at this large-scale international event. My name is Olga Yakovleva. I'm a professional micropigmentation expert and trainer areolar reconstruction specialist, aesthetic cosmetologist, and author of scientific articles. I would like to talk about the role of micropigmentation in medicine and psycho-emotional rehabilitation. My topic today is potential uses of micropigmentation in medical and psycho-emotional rehabilitation. Permanent makeup is often seen only as a beauty procedure, but in reality it can solve much deeper problems. It helps patients after trauma, surgery, and skin diseases. It restores not only appearance, but also confidence and quality of life. What is micropigmentation? Micropigmentation is a method of implanting pigment into the superficial layers of the dermis to create a long-lasting color effect. Originally, this technique was used only in beauty, for example, eyebrows, lips, or eyeliner permanent makeup, but today it's also used in aesthetic medicine for the reconstruction of the skin defects. Micropigmentation procedure can help correct scars, depigmentation, areolar reconstruction after mastectomy. And this makes micropigmentation not only cosmetic but also therapeutic. I would like to speak about main medical applications. One of its most clinically and emotional uses is the reconstruction of the areola in women who have undergone mastectomy as part of breast cancer treatment. Breast cancer is the most common oncological disease among women, second only to lung cancer in terms of mortality. Even with modern reconstructive surgery using implants or patients' own tissue, it's still difficult to fully restore the nipple areola complex. According to studies, women after mastectomy often experience serious emotional problems, such as low self-confidence, low self-esteem, anxiety, and feeling less feminine and attractive. Micropigmentation allows us to recreate color, shape, visual volume with use 3D techniques for realistic effect. Restoring the color and shape of the areola with tattooing helps complete the recovery after surgery, improves how the breast looks, and has a positive effect on a woman's emotional well-being. Patients often feel yourself more feminine, more confident, more complete. Micropigmentation becomes part of full rehabilitation. This is not only aesthetic, it's a very important psychological step. It's important to understand that micropigmentation requires a high level of professional training, including knowledge of anatomy, color, and how the skin changes after surgery. If there are scars after reconstruction, camouflage techniques can also be used. Micropigmentation can be used not only for aesthetic enhancement but also for medical camouflage. This is work with scars and vitiligo. Scars may result from surgery, trauma, inflammatory skin conditions. It does not remove the scar, but it makes it less noticeable. Vitiligo is a condition with loss of skin pigment. It creates white patches on the skin. These areas can be very visible. Micropigmentation helps restore color. This is especially important for face, hands, visible body areas. Despite various treatments, for example, laser therapy, injections, surgery, not all patients achieve satisfactory results. Micropigmentation restores color uniformity, reduces visual contrast, improves overall skin appearance, supports psychological condition. How permanent makeup expert is performing the procedure? Of course, first is consultation. We examine the patient, skin conditions, scars, medical history. We also discuss expectation. It's very important to explain. possibilities, limitations, and get informed consent. The consultation and the procedure can take place on different days, as the patient may need time to make a decision and feel comfortable and confident. Next step is the day of the procedure. Preparation clean skin, where cleaning antiseptic is. We create a sketch. Artist selects correct shape if it's areola, correct color for clean skin, correct technique for work. We use professional machines, sterilized single-use cartridges, and pigments. There are 3 types of pigments: mineral, organic, and hybrid. Each artist chooses what works best for their style and technique. All types can be used, but it's important to understand the differences and the highlight results. Mineral pigments usually give a softer and lighter highlight effect and fade faster, so touch-ups are needed more often. Organic pigments are the most highly pigmented among these types. They stay in the skin longer and give brighter highlight results. However, they are less stable when exposed to external factors like sun or salt water. Hybrid pigments are very popular because they combine the advantages of both mineral and organic pigments: a wide color range, good stability, less frequent touch-ups, and more stronger highlight results. It can be different company. Important is safety. We always use barrier protection, disposable cartridges, disinfect all working surface, work only with gloves, and pour pigment into single-use cups. Different title types are used depending on the task. For example, round liner, magnum, shader. Pigment is implanted into the skin step by step. We work from general shape to details. We add shadows, highlights, if needed, for example when working in the areola area, to create more volume and a more natural effect. This creates a natural result. After the procedure, patient receives care instructions. Healing takes about 1–2 months. After that, we usually perform a second procedure. The second procedure allows us to evaluate how well the pigment has settled in the skin, adjust the color and density, and improve the final result. It helps to match the tone of depigmented areas with healthy skin in cases like scar or vitiligo camouflage. It can also add more volume, brightness, and color, for example in areolar reconstruction or eyebrow restoration in alopecia. Any micropigmentation procedure requires skills, knowledge of anatomy and skin structure, and understanding of color selection. This is especially important when we work with aesthetic skin defects, as patients often already feel uncomfortable after their condition or illness. The specialist cannot make mistakes. The goal is to improve the appearance of the treated area, not make it worse. Mistakes can lead to poor results, complications, leading to even deeper depression, loss of confidence, and social withdrawal in patients. This positions micropigmentation as a truly interdisciplinary tool, one that requires an ethical framework and standardized professional training. I believe that micropigmentation should be part of patient rehabilitation, working together with other medical fields: dermatology, surgery, oncology, and psychology. This will help achieve better and more visible results. This method does more than improve appearance. Studies show that patients feel more comfortable in society, build better relationships, and avoid social situations less often. Improving appearance helps patients return to normal life, feel more confident, and communicating more easily with others in both work and personal life. By improving skin defects, patients can feel more in control of their body, restore their identity, and feel more confident in society. Research shows that restoring features like eyebrows or areolas after medical treatment can increase self-esteem and reduce anxiety and depression. In conclusion, micropigmentation is a powerful medical and rehabilitation tool. It helps restore appearance, improve emotional condition, increase quality of life. It gives patients something very important, a sense of normal life again, and this is the real value of our work. With this, I would like to conclude my presentation. Thank you very much for your attention. This is a very broad topic, but I try to briefly present the modern possibilities of micropigmentation in correcting aesthetic skin defects and supporting patients' psychological rehabilitation for therapeutic purposes. Thank you very much for your attention. I'm very pleased to be part of this conference. See you soon. Bye.
Good afternoon, everyone. My name is Amna Samad. I'm a researcher and a student from National University of Science and Technology, Islamabad, Pakistan. So today we are going to set aside all that chemical stereotyping and diving straight into the cosmetic chemistry behind a very specific product, the jellyfish scrub, poppy seed jellyfish scrub, which was formulated by me. And this whole thing that we are going to unpack today is coming straight from the peer-reviewed article that was published in to make it clear that why I formulated this product. So let's study that why skins cannot be really needs exfoliation. It is an integument system for protection, which means that it is acting as a barrier between the environment and the internal organs of the human body. So this means that whatever is happening outside the body has ultimately an effect on our skin surface, right? And then on the inside of the body, most probably the immune system. Epidermis, the topmost layer. Epidermis, we have to make sure that the pH of this epidermis must be slightly acidic. The reason is that when the cells are completing their life cycle, the keratinocytes, they come on the surface, they complete their life cycle, they die, right? So then what is the next step? That a protein filaggrates. So because of these amino acids, the acidic metal is making sure that our skin's pH is between 4.5 to 5.5. Essential for two main purposes. Number one, the ceramides lipid matrix. We know that they are going to be formed in the acidic environment. And the second one, the most important one, is that the proton activated chloride channel, PACC1 protein, it is going to release the enzymes in this acidic environment to make sure that the gum or the desmosomes in scientific language, they are going to be disposed of or shed off from our skin surface. So this second point, PACC1 enzyme, basically we have to keep this thing in our mind that this is the main point of formulating this whole product. All right. So now the second layer, which is dermis and hypodermis, we know that they are responsible for providing the structural support, and the hypodermis is simply responsible for insulation and cushioning, right? But the main thing is that if the skin's pH is disturbed, the epidermis is disturbed, it will ultimately cause the structural support to demolish too. So we have to choose a product for our skin care that will maintain the pH of 4.5 to 5.5, which means slightly acidic. Okay. Now, the next thing, the need for exfoliation. Now, as I have told you that the keratinocytes, when they die, what happened that there is a need to shed off the dead skin cells. Okay, so when we have to shred off the dead skin cells, okay, the gum, we are going to demolish it. We have to use any exfoliant. Why we cannot use only the water? Because we know water is neutral, it is slightly alkaline. Okay, so it will not provide an acidic environment to PACC1 to trigger the enzymes and remove the dead skin cells. So we cannot use water alone. For that purpose, we are left with two choices: either the chemical exfoliant, okay, that we use in our daily life, and the mechanical exfoliant. Chemical exfoliant, what they will do, chemical exfoliants have alpha, beta, and polyhydroxy acids. Okay, but although we know they are beneficial for our skin, what happened with the passage of time, these alpha, beta, and polyhydroxy acids, they will simply damage the stratum corneum of the epidermis. Our skin will be exposed to more UV damage and more inflammation. Okay, in addition to that, with the rapid use or without the consultant of or any dermatologist, what will happen that this chemical exfoliation will lead to the exposure of the skin to the sun with bright UV damage, and the Langerhans cells that are present in the epidermis, they will be affected. Okay, they will overactivate the PACC1 enzymes, which means that now more and more shedding of dead skin cells will happen, and our immune system will be overactivated. So this means that that is the root cause that most of the autoimmune diseases in our body will start. For example, eczema, dermatitis, inflammation, these kind of diseases. So now if we move toward the mechanical exfoliants, what we can do is we are simply using the brushes, right? But we know that brushes don't know that our skin is acidic or basic, right? We have to choose the best product for our skin. So if we are going to use brushes, what will simply happen that brushes not only remove the normal dead skin cells but also remove the healthy surrounding dead skin cells. Okay, so now chemical exfoliants also fail and the mechanical exfoliants will also fail. This means that we have to shift towards the third choice, that is a gentle exfoliation. Okay, we are not going to use any chemical exfoliant as well as we are not going towards any mechanical brushes for harming our skin or causing micro tearing. Okay, so that is the purpose that I formulated this jellyfish scrub. And obviously, in order to formulate this jellyfish scrub, I had to do a lot of literature to pick the best exfoliant for my product that I was formulating. So these were the four choices. Basically, I made the choice based on the fatty acids because we are not using the alpha or beta or polyhydroxy acids. So my choice was the fatty acids. Now, number one is the linoleic acid. As you know, that it is omega-6 fatty acids. It provides nutrients and it provides the oxidative chain reactions that simply remove the oxidative reactions that are happening directly with our skin. So if linoleic acid is in high amount, then it is best we are going to select the product. But if we have a choice of oleic acid, oleic acid is again unsaturated, but it is omega-9 fatty acids. And if it is present in any exfoliant in a very large amount, it will be good for dry skin. Okay, but if we are going to use it on oily skin or acne prone skin, it will cause more congestion and cause more oiliness on the acne prone patients. So we have to select a product that have low amount of oleic acid. Now, if we move toward the third one, the palmitic acid, which is basically saturated, when this is applied on the skin, it feels so much heavy on the skin, right? So again, it is good for dry skin, but not for the acne prone skin. So we are going to use the product or the exfoliant which have high amount of linoleic acid and low amount of oleic acid and palmitic acid. So that's why I researched, and basically these were the four that were very competitive with each other. So on the basis of literature, I picked white poppy seeds, which has a high amount of linoleic acid and a very balanced amount of oleic acid and palmitic acid. Now, the next one, before moving towards the formulation, I wanted to share that why I added all of these ingredients. Okay, their percentages are given here because I wanted to create 100% natural product. But in addition to that, their concentrations were based on the literature and as well as in order to maintain the same thing, pH of the skin between 4.5 to 5.5. Now, the first thing, xanthan gum, it is a polysaccharide and it is totally non-comedogenic. And in addition to that, it doesn't cause any harm on the irritating skins or the sensitive skin. Sensitive skin. So, xanthan gum was selected, which was basically giving the viscosity and the jelly-like texture to the product. Glycerin was added, and it was added to act as a humectant here. And in addition to that, glycerin basically stores or lock in directly water on the straightened cornea. Okay. Now the water is basically added because of two purposes. First of all, distilled water, because we know that we don't want any mineral or ions reaching our face. And we also want to make sure that all of the ingredients are mixed up in the product. The second thing is that although poppy seeds don't contain even not even a 1% of morphine, but I wanted to make sure that while harvesting, there can be any opioid fluids that can be present, or poppy seeds can become contaminated. So I wanted to make sure that there will be not even a 1% of the contaminant present on the poppy seeds. So I washed it with boiling water in order to make sure that 100% of the contaminants will be removed from the poppy seeds. The next one, liquid germal plus, it was added to act as a preservative against the microbes. And in addition to that, it is completely free of any synthetic parabens. In addition to that, there is one more purpose, that it is also acting to increase the shelf life of the product. The last one, the white poppy seeds, our hero ingredient. Why this one was added? Because white poppy seeds, in contrast to alpha, beta, and polyhydroxy acids, they don't form any intercellular bonding or intercellular chemical bonds with the skin. So that's why these white poppy seeds were selected, and also on the basis of the balanced fatty acids present in them. So this was the percentage composition, but now let's move at how this concise recipe was prepared in the lab. Okay, first of all, blending was done. Xanthan gum and glycerin was added in order to make sure that there was no clumps or no agglomerates there. The second step, hydration, water was added. The third step, white poppy seeds, which were properly washed and oven dried, those were added. And the last step, pH stabilization, was taken place. I basically added 50-50 citric acid, because citric acid don't cause that much harm on the skin, although it is alpha hydroxy acids, but in compared to those alpha and beta polyhydroxy acids, this one is totally natural. So therefore, in order to maintain the pH of the product, I selected citric acid, 50 citric acid, and 50 distilled water. So 50-50 ratio was selected, and in that way, this product was formulated in order to keep the pH between 4.5 to 5.5. That will allow the normal PACC1 protein to trigger the enzymes and remove the gums or the dead skin cells from the skin surface that were either immature or that were clumping together because of any genetic mutation, like filaggrin gene mutation. Now, the testing of the product was done. The extrudability was tested basically. For example, if you are doing a skin care, obviously it will become too much frustrated if the product is not coming out of the tube, or it creates a complete mess on your hands, right? So we have to check the extrudability, and the value of spreadability comes out to be 7.4, which basically matched the literature. And that's how I created a product that has a balanced um, extrudability quality. Not too much rinsing off and not too much creating mess on the skin. Now, the next one is the effectiveness in terms of stability. So, the most important factor that I'm going to discuss here is irritability. As we know that if you are going to use any steroids, if you are going to use any allergens, what will happen on the skin? Stinkiness can happen, right? So, in order to check that my product is feasible for both the allergic patients, for both the dry skin patients as well as acne prone patients. So all of them were tested, and on the basis of literature, that formulation was best for them. And there was no signature of any hives, any edema, there was no erythema, no swelling that we observed in the lab. In addition to that, the packaging was also tested and the thermostability was tested in 2 rounds. In the first round, basically, I tested for days and at various temperature ranges. And in addition to that, in the second round, I tested for several weeks. So the product showed 6 months shelf life stability in the glass container rather than the plastic container. Because glass container is inert, there was no entry of moisture and the product didn't degrade. Now, in contrast to that, when I observed in the plastic container, what happens that, as you know, that plastic have polymers, they have pores in them, so oxygen, light, or any of the moisture content can easily enter the bottles and harm the concentration or the formulation of the product. So that's how the product was tested in both of the jars. So this means that whenever we are using the skincare products, we have to make sure that what kind of bottles they are using to have stored the product in the containers. And secondly, we have to check that what kind of acids are used in the formulation of the products, right? Because the pH, if that is disturbed on the skin, ultimately the lower layers will be affected and the person can become susceptible to autoimmune diseases. Now, phytochemicals were also tested and only flavonoids, phenolics, and alkaloids were present. So flavonoids is a key here because we know that flavonoids and phenolics, they are highly essential to make sure that the product is antibacterial, it is photoprotected, and in addition to that, it also provides the anti-inflammatory effects, right? But that is not just a theoretical thing. You can also visualize the results by the UV visible spectrum. As you can see that there were two distinct peaks at 270 and 297 nanometers. So if you match them with analytical chemistry, these peaks correspond to phenolic acids and flavonoids. So these two phytochemicals were present in the product and were making sure to make the or to increase the efficiency of the product formulated. Now, lastly, I would like to end the session with a clear thought that whenever you are going to use the product, whether you are going to choose a product that is chemically formulated or you are going to use a product that is based on the natural synthetic paraben free products. In addition to that, you have to just keep this sentence in your mind that the products that are formulated from oil seeds are more safer, simpler, and more easier to use than that of the chemical exfoliants, because chemical exfoliants initially feel better, but with the passage of time and on the basis of literature and in the patients in which there are more melanin pigments produced, what happens that they are causing autoimmune diseases. So this thing basically needs more literature studies, more studies in the countries and in the regions is needed, in which more patients with melanocytes and melanin pigments must be tested, because that could be the root cause, and they are not even aware that this slight mistake is causing such difficult and I would say that more environmental hazardity, because plastic is also used diseases in the environment that is not only affecting the human beings but also the aquatic organisms. So these were the references from which I have studied my literature, and my presentation was based on that data. Thank you very much.
Thank you. Thanks. The title of my network meta-analysis was Comparative Effectiveness of 4 Biological Therapies for Moderate to Severe Plaque Psoriasis. We did not include the psoriatic arthritis, so it's only testing adults, moderate to severe, and plaque psoriasis. And before we jump in, can we just go to the next slide, please? The next slide, next one. Yeah, before we delve into the network meta-analysis, there is a little bit of disclosure, and there was no conflict of interest. There was no financial support received from any organization, including the pharmaceutical companies. And there was no personal fees. And I would like to thank our statistician who was a freelancer, Nigerian freelancer. He lives in Nigeria. His name is Balogan. Much thanks to him and for doing the statistical part, and the research was conducted in full independence. The next one. Yeah, thank you. So a little bit of background about psoriasis. So psoriasis affects 2 to 3% of the global population, as you may know. It's causing significant impairment. It's not just a skin disease, it's also mental health. It's causing mental health problem, quality of life is affected, and the social function is affected. The second part is there was a knowledge gap. So before we did there is many network meta-analysis comparing the biological therapies given in severe psoriasis, but they were predate the bimekizumab phase 3 trials, the 4 trials that we are our main focus is that what was the bimekizumab. So the trials were Be Sure, Be Radiant, Be Vivid, and Be Ready, and lack head-to-head comparisons incorporating bimekizumab. So the biological therapies usually they are targeting the cytokines, as we know. So previously they were targeting tumor necrosis factor alpha. The current ones more towards interleukin 12 and /23, 17 or 23 alone. And the newest one is the bimekizumab. It's a dual interleukin 17A/F, and it is the newest agent. I think the most commonly used one in the UK is this one. New direct evidence. There was 2 studies that we included, Emerge and Be Radiant, provide valuable head-to-head data to anchor this network. So where does bimekizumab sit in the current treatment hierarchy within the many biological therapies? This is what we're trying to test. Our study objectives was to compare the effectiveness of these 4 against the 4 ones. I apologize from now for the funny names. Their names are so funny. Bimekizumab, secukinumab, risankizumab, and guselkumab against adalimumab, and the other one was ustekinumab for moderate to severe plaque psoriasis. And of course, we want to establish the hierarchy. The indicator of effectiveness that we used was PASI 90. PASI is the severity score of psoriasis area and severity index at 16 weeks. So basically testing how many percentage of patients that received the X medication, the biological therapy, achieved 90% resolution of the initial psoriasis after 16 weeks of treatment. We faced some problems that some of the trials were good to be included, but we didn't include them because they did not mention exactly the PASI 90. We wanted something common in between all the trials to be included as the indicator. And the other one was to assess consistency, the other objective. Next, please. Yeah, thank you. So actually, let's go back. Let's go next to the study selection, the other one. Next. Yeah, thank you. So our study included 642 records identified. We used PubMed and the clinical trials. We looked through 259. The research. The search included 259 trials from PubMed and 383 from clinical trials. We screened 241. We removed the duplicates, which was 400. And then the next one was we ended up with 45 full text, but some of them were excluded for many, many reasons. One of them, as I said, they did not mention the severity index 90, PASI 90 at week 16. Some of them is not phase 3 trials and other causes. Not only these four, many causes, they were not included. There's many exclusion criteria in the network meta-analysis that we did. We ended up with testing 11 phase 3 trials, but they were included in 10. It was Voyage 1 and 2 included in one database, included in one paper. So the included trials were the next one, including trials were Be Sure. The first for the B studies is for bimekizumab, comparing it to something else. Be Sure, Be Radiant, Be Vivid, and Be Ready, comparing bimekizumab to a placebo. Be Sure, Be Radiant, comparing it to secukinumab and placebo. Be Vivid, comparing it to ustekinumab. Be Ready, also comparing bimekizumab to placebo. I think the difference between the Be Sure and Be Ready, like one of them included 30% of the patients were not biological naive. They used prior biological therapy, and this will be mentioned in the consistency later. Also, we included other studies, Clear, Voyage 1 and 2, Emerge, Ultima, and Invent. The total number of patients were 6,652 across 10 databases, representing 11 phase 3 trials. Next. Yeah. As I said, the total number of patients were like more than between 6,000 and 7,000. And we found these criteria, the patient's characteristics, actually, the average characteristics across the studies. And I believe, like, since it is testing 6,000 patients with psoriasis, maybe this is the real demographic of psoriasis. So as we can see that the mean age was 45, 68% of them were male sex. The baseline severity of psoriasis was 21. 21% of their body was affected as baseline. 30% they tried different biological before. The disease duration was at least 18 years, and 95% only of them finished week 16 of treatment. Some of them, they just drop out of the trial because of side effects, because of many things. They don't want to be included in the study anymore for any various reason. Yeah, thank you. Treatment geometry. So as we can see in this graph that we are testing, the top 4 is the ones that we are testing, including bimekizumab, guselkumab, and secukinumab, and risankizumab. The comparators are the lower 3, adalimumab, ustekinumab, and placebo. We can see there's many direct links between each one and another. And there is also, if there is no connection between two nodes, for example, the placebo and ustekinumab, there is some sort of indirect link, because ustekinumab, for example, is linked to secukinumab and placebo is linked to secukinumab. So we could make this comparison between the two medications or comparators, placebo and ustekinumab, although they were not compared directly to each other. Next. Next, please. Yeah, thank you. The main results that we had, as I said, our indicator of the effectiveness was how many patients achieved 90% resolution of the initial psoriasis after 16 weeks as compared with the placebo. We calculated the odds ratio, and bimekizumab is by far was the winner. Basically, the odds ratio was 170. So basically, if we are testing people who received bimekizumab versus placebo, there's 170 chance more that they will achieve the 90% resolution of their psoriasis after 16 weeks if they used bimekizumab versus placebo. The second one in our study, the result was risankizumab. The odds ratio was 95 as compared to the placebo. The other one, guselkumab, secukinumab, is the fourth one. And then the other ones was also adalimumab. The odds ratio was 30. Ustekinumab, the odds ratio was 26. All comparisons were statistically significant. The P ratio was less than 0.001. And there was low heterogeneity. I-square was 0%. So as we can see here, we tested 11 clinical trials to see which biological therapy was more effective in achieving psoriasis clearance, 90% of psoriasis clearance after 16 weeks. And bimekizumab was by far, there's a big difference between it and the others. Next. Sorry. Yeah, so there is also, so that one, the previous one is comparing each medication to placebo, but we did many head-to-head comparisons. I just want to mention the first three, which is bimekizumab versus anything else was also higher. So bimekizumab was 2.25 more likely to cause clearance than secukinumab. Bimekizumab, for example, the odds ratio as compared with risankizumab was 1.75. Also, the odds ratio was also positive 2 as compared with guselkumab. Yeah, next. Thank you. The other one is the league table. I will not go through this table, all of the table, but I also would like to highlight that the line of bimekizumab is always always positive. It's always more effective than anything else. As we said, it's 170 more effective than placebo, as odds ratio is 170. But also it's more effective than the first column, which is adalimumab 5 times, 2 times guselkumab, 1.78 to risankizumab, 2.25 to secukinumab, and 6.37 to ustekinumab. So as we can see, it's always the winner here in our study. Next slide is talking about the heterogeneity and the consistency analysis. The heterogeneity in indicators were 0%, the I-square and chi-square. There was some notable exception, as I said, between bimekizumab and placebo, because it was tested in 2 different studies, but one of them was biological naive, and one of them was people, 1/3 of the patients were experienced, they tried different biological therapy before bimekizumab. So there was some inconsistency, but this one is, I think it's related to the population of the study. Yeah, and then there is also the direct and indirect alignment. Our conclusion is the network evidence is consistent and reliable across all treatment comparisons. I will not go through the other things because it's mentioned in the network meta-analysis, but I don't think it's of any importance to mention here. Next slide, please. Yeah, thank you. So again, this graph showing the hierarchy that we found, bimekizumab is by far more winning than the other therapies as compared with the placebo. Yeah, of not to mention that each medication was belonging to different class. Bimekizumab is interleukin 17A/F. Risankizumab is interleukin 23p19 inhibitor. Guzel also 23. Secukinumab is interleukin 17A, and adalimumab is the old one, which is TNF alpha inhibitor. Next. One second, sorry. Yeah. why dual inhibitors, interleukin-17 AF, mechanism advantage uniquely targets both interleukin-17A and interleukin-17F. So basically, both components are cytokines. We are targeting them to prevent psoriasis. Psoriasis is immune condition. There's many cytokines involved in the mechanism. Targeting one of them will possibly, hopefully, make the cure. Interleukin-17F is independently promotes keratinocyte activation and neutrophil recruitment. The pathway was not addressed by secukinumab. Okay. This one is also mentioned that the lowest line, higher rates of oral candidiasis with bimekizumab as compared with the other factor not shared decision making. This is very important. That we said that bimekizumab is more effective than the others are, as we compare it with all the other medications was more effective. But also it came with higher rate of oral candidiasis, more side effects. Maybe because it's more strong, like it causes more side effects, but it's something that should be mentioned when we choose the medication. And the patient, of course, should be involved in the decision making. Next, please. Next. Okay, thank you. Interleukin-23 inhibitors, a comparable and practical cluster. So, risankizumab versus guselkumab, the odds ratio was 1.16, but the confidence interval included 1, so there was no really statistically important difference between them, between risankizumab, guselkumab. Both of them are interleukin-23 inhibitors. Both of them are less effective than bimekizumab, but they come with some certain advantages. One of them is they are less frequent dosing, so the patient does not have the injection every week. For risankizumab, as we can see in the second box on the left, risankizumab is every 12 weeks injection, which is really nice for a patient to, in terms of if they are working, if they are busy, they can come every 3 months to have the injection, and that's it. Guselkumab is every 8 weeks, so every 2 months. So they are more practical to the patient. Okay, they come with less effectiveness, but sometimes the practicality should be also taken in mind. And also, as we said, it's less risk of oral candidiasis as compared with bimekizumab. Okay, they are less effective, but there are some positive sides to each one. Both of them are more effective than the old one, adalimumab. For patients prioritizing convenience. Okay, so for the convenience of patients, interleukin-23 offer very nice way. They don't have to inject something every day or every week. It's every 12 weeks, every 8 weeks, and they come with less side effects. Next, we will talk about the study limitations. We should be aware that our study has many points limiting as limitations. One of them is we are testing the treatment effectiveness at 16 weeks. We are not sure what will happen after 1 year. Some side effects happen after 32 weeks, after 1 year. So it's not about the long-term durability and maintenance. Okay, we said that bimekizumab is more effective, but we are testing it after 16 weeks of therapy. We are not sure what happens after that. So possibly in the future, when bimekizumab is more and more being used, we will be able to test this and test the long-term effectiveness and the long-term safety profile. Also, all the trials were industry sponsored, but there were many different industries, so we are it's like distributed, so it provides some reassurance. No comparative safety analysis, as we said, there is the safety analysis was not analyzed, as we said, because we are testing only 16 weeks. We're not sure what will happen after that. And we used only 2 databases, PubMed and the clinical trial. we did not do M-Base and Cochrane, unfortunately, although they have some more phase 3 trials. And as we said, there is some inconsistency comparing bimekizumab compared to the placebo, because there's two studies included. One of them is biological naive, one of them is the patients were using biological prior to that. The next one we'll talk about the next slide. We'll talk about, thank you, the clinical implications for high clearance seekers. So we have so many results from our studies. This can be implicated in the treatment choice. Actually, it can be put even in the guidelines. So I'm working on this. I'm with the Psoriasis UK. I sent them an email about the results to put this in mind. Like, we have, if the patient is seeking high clearance rate, of course, bimekizumab is the one. As we said, it's highest effectiveness. If someone is experienced on secukinumab, they can consider switching to bimekizumab or others, which show high effectiveness rate. Comorbidities matter. We did not include IBD patients. We include only patients who have psoriasis only, but some patients have joint or bowel problems, and this will affect the treatment choice in many cases. So in cases of IBD, for example, bimekizumab is contraindicated, possibly. Convenience-driven patients, as we said, if they seek less dosing intervals, then risankizumab and guselkumab will be effective, because it's the injections every 12 or 8 weeks. If the patient is an older biological and is not working, although it's not causing some side effects, I think it's better to change to the newer ones. And of course, shared decision making is always, we give the patients all the information and they will choose. It's their decision in the end. It's their disease and their treatment. They are the center of the treatment. So you consider that this medication, I think it's more effective, but it comes with these side effects. This one is less effective, but it has less side effects. You choose, and they will be involved in the decision making. Next, please. Next, we will come to the conclusions. Yeah, thank you. So the first conclusion is bimekizumab leads. It has highest PASI 90 effectiveness at week 16. Those ratios compared with the placebo was 170 and statistically superior to all other comparators. But as I said, it comes with some side effects, higher side effects of oral candidiasis. Interleukin-23 are also strong. They have less side effects and less frequent dosing, and they have some practical advantage over bimekizumab, although they are less effective. Third one is secukinumab remains relevant. Odds ratio as compared with adalimumab, it's more 2.49. Slightly still high effectively option, though outperformed by the newer agents. So, but it's not still better than adalimumab. The older one lag behind adalimumab, secukinumab, shows similar lower efficacy. Patients on these should be considered or may be considered for escalation of consideration of escalation. Some patients, they are happy with the treatment. They don't want to try something new, and possibly in the next year it will cause them some side effects. They don't want to try. So it's worthy to mention to them, but in the end, they are the one who decide. The last one is the network was, I think it was robust. The inconsistency was 0 globally. There is no significant inconsistency, and high confidence in all network estimates. The last slide is, I would like to thank you for having me in this.
Good afternoon. My name is Tanya Ghosh. I am a Foundation Year 1 doctor in the KSS Deanery in the United Kingdom, and today I will be discussing body dysmorphia disorder, a critical role for dermatologists, under the supervision of Dr. Eric Blair at QMUL University. This presentation explores the recognition and management of body dysmorphic disorder, or BDD, with a particular focus on its relevance to dermatology and cosmetic practice. Specifically, I will be discussing the clinical features of BDD, why it frequently presents outside of psychiatric settings, and findings from a systematic literature review investigating current management approaches in adolescents. Importantly, I hope to highlight why recognizing BDD early is essential, not only to improve patient outcomes, but also to prevent harm resulting from inappropriate cosmetic intervention. Before discussing management, it is important to first define what body dysmorphia disorder actually is. Body dysmorphic disorder is a psychiatric disorder characterized by pathological dissatisfaction with appearance. Individuals experience persistent and distressing preoccupations with perceived physical flaws that are either non-existent or objectively minimal to others. However, this extends beyond ordinary insecurity and dissatisfaction with appearance. These beliefs are often rigid, obsessive, and at times delusional in intensity. Patients commonly engage in repetitive compulsive or safety behaviors intended to reduce anxiety or conceal the perceived defect. These behaviors include mirror checking, excessive grooming, camouflaging, reassurance seeking, skin picking, and repeated changing of clothes. According to the DSM-5 criteria, the appearance preoccupation must be time-consuming, generally occupying more than 1 hour per day, and this must lead to clinically significant distress or impairment in functioning. BDD is also differentiated from eating disorders. If the concern is solely related to body fat or weight, then an eating disorder diagnosis should instead be considered. Another clinically relevant feature is level of insight. Patients may recognize that their concerns are excessive, but many demonstrate poor insight or even fixed delusional beliefs. This has important implications for treatment success and help-seeking behavior. Muscle dysmorphia, a subtype of BDD, is also important to recognize, particularly amongst young males, where individuals perceive themselves as insufficiently muscular despite objective normality. BDD rarely presents in psychiatric settings, despite being a severe psychiatric disorder. Instead, many patients present to dermatologists, cosmetic clinicians, or surgeons seeking correction of what they perceive to be a physical defect. This becomes particularly important when we consider the associated psychiatric burden. BDD carries high rates of psychiatric comorbidity, marked functional impairment, and notably elevated suicidality. So, why is BDD particularly relevant to dermatology? The answer lies in where these patients present. Individuals with severe BDD, especially those with poor insight or delusional beliefs, are significantly more likely to seek dermatological or cosmetic intervention than psychiatric care. In other words, the dermatologist or cosmetic clinician may be the first and perhaps only healthcare professional to encounter these patients. Research suggests that the prevalence of BDD is especially high in cosmetic and dermatological settings, with reported prevalence rates of approximately 11% in dermatology clinics, 20% amongst rhinoplasty patients, and over 13% in cosmetic surgery settings. Importantly, cosmetic intervention does not reliably improve symptoms. Only a minority of patients report sustained improvement in appearance concerns after cosmetic treatment. For most individuals, the preoccupation remains, often shifting to another perceived flaw or persisting despite objectively successful procedures. As a result, overall quality of life often remains unchanged, which raises both ethical and clinical concerns. A patient experiencing a psychiatric disorder may undergo an unnecessary intervention without meaningful benefit, while dissatisfaction after treatment may also contribute to conflict or even litigation directed towards cosmetic practitioners. It is therefore essential that clinicians are able to distinguish BDD from more common body dissatisfaction, obsessive-compulsive disorder, or eating disorders. Normal body dissatisfaction tends to fluctuate and does not cause significant impairment in their daily life. Obsessive-compulsive disorders may involve repetitive behaviors, but it is not specifically appearance-driven. Similarly, eating disorders are centered around body weight and shape rather than perceived isolated flaws. Recognition, therefore, becomes a clinical safeguard, both for patient well-being and professional practice. To better understand current management approaches, this work examined the available evidence through a systematic review methodology. A PRISMA framework was used to guide study identification and selection. Literature searches were performed using PubMed and PsycInfo, accessed in February 2024. The inclusion criteria was intentionally specific. Only English language, peer-reviewed journal articles were included. Studies needed to focus specifically on body dysmorphia disorder, be treatment-related, include adolescents aged 10 to 19, and be published between November 2005 and January 2024. Studies concerning obsessive-compulsive disorder, eating disorders, general body dissatisfaction, or unrelated psychiatric pathology were excluded in order to preserve diagnostic specificity. Similarly, literature unrelated to treatment, such as epidemiology, prevalence, pathophysiology, or risk factor studies, were excluded. The rationale for focusing on adolescents was deliberate. Adolescence represents a particularly vulnerable developmental period in which body image concerns intensify, insight may be reduced, and psychiatric outcomes often worse. Furthermore, this age group experiences substantial psychosocial pressures related to appearance, increasingly shaped by social media and our digital culture. One key finding from the literature concerns limitations in our current treatment frameworks. Historically, clinical approaches have frequently grouped adults and children together. However, this may be problematic. Children and adolescents often represent a higher risk population with poorer insight, greater vulnerability to fixed beliefs, and increased suicidality. As a result, management strategies effective in adults may not fully address the development and psychological need of younger patients. A second limitation concerns the conceptual grouping of BDD alongside obsessive-compulsive disorder. Although BDD shares compulsive features with OCD, some researchers argue that the underlying mechanisms differ sufficiently to warrant more distinct approaches to diagnosis and treatment. Another challenge is that much of the guidance informing current practice is relatively outdated. For example, the NICE guidance referenced in much of the literature dates back to 2005. This raises an important question. Does historic guidance adequately reflect the reality of today's adolescents? The cultural landscape surrounding body image has shifted dramatically. Young people are now exposed to unprecedented appearance comparisons through social media, filters, image editing, influencer culture, and algorithm-driven beauty standards. This environment likely contributes to increased body dissatisfaction, which may act as a precursor to clinically significant BDD. In terms of practical application, the literature strongly supports routine vigilance and screening within cosmetic and dermatological settings. Lavelle and B, referencing NICE guidance, recommend that all patients requesting cosmetic procedures should be screened for possible BDD through focused questioning. Examples include asking, "Do you worry a lot about the way you look, or wish you could think about it less?" What concerns do you have about your appearance? How many hours per day do you spend thinking about this? And importantly, what impact does this have on your life, relationships, or functioning? These questions are valuable because they move the consultation away from appearance alone and towards psychological burden and functional impairment. Another important finding relates to persistent delusional beliefs. Evidence suggests that if these beliefs remain despite psychological intervention, patients may continue to seek cosmetic procedures in an attempt to resolve what they perceive to be a concrete physical abnormality. Paradoxically, cosmetic interventions may reinforce the delusion rather than alleviate it. This highlights the importance of recognizing BDD before intervention rather than after unsuccessful treatment. For clinicians, particularly dermatologists and cosmetic practitioners, this means developing confidence in identifying red flags, such as disproportionate distress, repetitive checking behaviors, repeated cosmetic consultations, unrealistic expectations, or social withdrawal related to appearance concerns. To conclude, body dysmorphic disorder is a severe but frequently under-recognized psychiatric condition that commonly presents in dermatological and cosmetic settings rather than psychiatric services. Because these patients often seek non-psychiatric care, dermatologists and cosmetic clinicians occupy a uniquely important position in early recognition. Failure to identify BDD may expose patients to unnecessary procedures that do not improve quality of life and may worsen distress. Routine vigilance is therefore essential. Validated screening tools, such as the Body Dysmorphic Disorder Questionnaire Dermatology version, or BDDQ-DV, provide a practical, cost-effective, and time-efficient method of identifying high-risk patients. Where concerns exist, referral to psychiatric or psychological services should occur prior to cosmetic intervention. Particular vigilance is warranted amongst adolescents and young adults, given the high burden of psychiatric risk, reduced insight, and increased socio-cultural pressures surrounding appearance. As psychodermatology services continue to expand, interdisciplinary collaboration between dermatology, psychiatry, and psychology may become increasingly important in meeting patient needs safely and effectively. Thank you very much for listening, and I welcome any questions. Thank you.